Меня зовут Алексей Сидник. Я руковожу компанией Senior Group. Компания Senior Group, которую я возглавляю, ей 12 лет. Мы работаем в Москве, Московской области. Мы собираемся работать в Санкт-Петербурге и Ленинградской области. Наш фокус – это помощь пожилым людям. Мы помогаем пожилым людям в специализированных учреждениях, у нас их 7. И мы помогаем пожилым людям на дому. Когда мы говорим «помогаем», это, конечно, уход, это гериатрическая реабилитация, это организация патронажной службы на дому. В настоящий момент у нас примерно 400 мест в стационарных учреждениях, и более 2000 людей получают нашу помощь на дому. Наша философия, вот когда мы только начинали делать, наша философия компании была, что мы это делаем для людей, которым мы помогаем, что мы прежде всего видим личность, вне зависимости от того, в каком состоянии находится тот человек, который у нас живет или к которому мы приходим домой. И это очень важно. Да, мы все говорим про российскую благость души, вот, и это здорово, это нам очень помогает. Но, как мы выяснили достаточно рано, что благость души этого недостаточно для того, чтобы оказывать качественную помощь. И дальше мы выяснили, что качественный уход – это на самом деле весьма и весьма стандартные и понятные процедуры. И что этому нужно учиться, что это технология. И представляете, да, технологии, которые направлены на то, чтобы человеку было хорошо. Вот что мы делаем? Можно, наверное, сказать, что мы продлеваем жизнь, но я бы по-другому сказал. Я бы сказал, что мы добавляем жизни к годам. То есть люди, которые у нас находятся, это люди в основном в очень тяжелом состоянии, которые не могут жить без постоянной посторонней помощи. Понятно, по возможности, конечно, лучше находиться дома, но чтобы они чувствовали себя здесь как дома, но прежде всего, чтобы они чувствовали себя здесь в безопасности. Когда мы говорим о безопасности, это не пожарные выходы, и не только пожарные выходы. Безопасность – это когда тебе понадобится помощь к тебе придет. Когда ты не сможешь что-то сделать, тебе кто-то поможет. Когда тебе одиноко и грустно, кто-то рядом подойдет и поговорит. Когда ты потерялся, ты сможешь себя найти. Безопасность – это когда человек наиболее долго остается автономным и может сам себя обслуживать хотя бы в каких-то элементах. Безопасность – это когда мы не крадем самостоятельности людей. Да, когда нам, как персоналу, гораздо легче взять и покормить человека, но мы будем сидеть и ждать, чтобы человек сам продолжал что-то делать, чтобы эта функция не утрачивалась. И понимая о том, что мы это делаем для людей, мы не забываем тех людей, которые у нас работают. Я хочу попросить сотрудников и членов нашей команды, поднимите, пожалуйста, руки. Вот, здорово, вас много, это хорошо. Когда мы разрабатываем, я об этом чуть позже расскажу, разрабатываем эти здания, всегда есть первое – это люди, которые здесь живут, второе – это люди, которые здесь работают, и третье – это инвесторы, но мы тоже о них думаем, но они в последнюю очередь. Часто это бывает наоборот. Итак, вы понимаете, какая философия. Я хотел немного рассказать о центре в Жуковке. Это наш 7-й центр. Он на самом деле не совсем такой, как мы бы хотели. Это здание, которое уже здесь было, и мы вынуждены были делать максимум в условиях ограничений. И я начну со слов благодарности Клавдии. Клавдия Консон, вы все ее знаете, но возможность поговорить с ней будет. Когда мы работали с Клавдией, мы сразу сообразили, что действительно весь тот мировой, не израильский, а весь тот мировой опыт, который есть в этой сфере, Клавдия каким-то удивительным образом аккумулирует и может это перевести на язык, понятный нам. Вот. И поэтому, я вижу здесь коллеги Клавдии из Израиля, они кивают, потому что это так. Клавдия работает и в Израиле, и в России, привнося лучший мировой опыт. Поэтому огромное спасибо Клавдии, огромное спасибо Наташе Алексеевой, которая управляет этим центром. Огромное спасибо всей команде. Потому что мы знаем, что управляющий руководитель – это одно, но самое большое спасибо – это тем людям, которые здесь работают. Да. Это медсестры, это помощники по уходу, это врачи, это психологи. Итак, центр Жуковка, он работает, он рассчитан на 60 мест. Здесь у нас всего 2 этажа. Здесь этаж номер 4 и этаж номер 5. Здание позволило нам на самом деле сделать чуть-чуть по-другому, чем, например, мы сделали в Малаховке. Здесь, как вы видите, нет коридоров. И это здорово, потому что, ну, во-первых, люди, когда выходят из своих комнат, они сразу оказываются в социуме. Здесь достаточно пространства и воздуха для того, чтобы мы могли организовать те или иные зоны. Здесь, где вы находитесь, есть зона, где люди могут поесть, есть зона, где можно позаниматься. Здесь есть медсестринский пост, с которого все видно. И здесь 4 таких отделения. Понятно, что классическое отделение в нашей отрасли, оно должно быть больше. В классическом отделении это примерно 30, ну максимум 40 человек. А здесь всего 15. Вот поэтому для нас, конечно, у нас сестринский пост в каждом отделении, но зато вот такая вот камерность, она позволяет нам делать интересные вещи. Она позволяет нам разделять наших пациентов, наших подопечных по группам, что вы, когда пойдете на экскурсию, мы пойдем в отделение, где будут люди, которым нужен большой объем помощи. Есть отделение, где люди более самостоятельные. Вот поэтому здание позволяет такие вещи делать. Вот. Ну и, конечно, как вы видите, и цвета, и вы увидите картины, навигация. Мы об этом расскажем уже непосредственно во время наших экскурсий. И прежде чем мы пойдем на экскурсии, я хотел рассказать, чего ожидать в сегодняшнем дне. Мы сегодня пришли для того, чтобы встретиться, задать вопросы и поговорить профессионально о деменции. Я хочу поблагодарить доктора Цви Дволацки. Он сидит здесь, у него будет еще официальное представление. И мы начнем.
Давайте общаться, разговаривать и ждем. А сейчас пока появление прекрасного человека, который, что для меня тоже было открытием, я с трепетом и с удивлением вообще изучала информацию об этом, что в 1998 году он открыл ведущую клинику по лечению проблем памяти, Memory Clinic, и был ее директором в течение 17 лет. Сейчас он возглавляет гериатрическое отделение в Рамбам Health Care Campus в Хайфе, президент гериатрического общества Израиля и также входит в состав Минздрава Израиля, да, членов. Мы встречаем, я немножко волнуюсь, я прошу прощения, потому что я боялась, что я допущу какую-нибудь ошибку в таких невероятных регалиях, поэтому я приглашаю сюда Цви Дволацки, профессор, проходите, пожалуйста. Здравствуйте. 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 Nice to meet you. Первый вопрос, который я бы хотела задать, касается, естественно, системы гериатрии в Израиле. Как она устроена и почему, и что такого особенного в ней есть, что весь мир равняется на нее. Это очень важная и ценная, мне кажется, информация.
Before I answer your question, I'm very impressed and very pleased to be here at this meeting of the senior group. As you mentioned, I've been working with Claudia for many years. We started together in Beersheba, and Claudia and I designed a memory clinic. And there were only 2 things that I did in the memory clinic, apart from seeing patients with Claudia. One thing is that we made a teaching unit where students could sit in one room and watch how we do cognitive testing in the other room. Claudia, that was my idea. And the other thing was that we decided to put up paintings in the memory clinic on the walls, and I decided what paintings would be. We went to Mr. Goodin, and Claudia let me choose the paintings. But everything else, Claudia did. And when I walked in here and saw this beautiful center, I said, I can see the hands of Claudia, but the movement, the energy of Alexei and the senior group, so I'm very, very pleased to be in. So in answer to your question, geriatrics, I think, is a field that for most countries in the world, is one of the youngest specializations, although we deal with old people, but as a specialization, it's a very young specialization. Geriatrics started as a profession in the late 1940s, early 1950s in England. In Israel, it only became a profession in the 1980s. And I am honored to be on the European Geriatric Medical Society on the board, and still many countries in Europe do not have geriatric training. And here in Russia, it's fairly new, as you all know. And tomorrow, I think it's the first geriatric conference in Russia, tomorrow. So why is it so important to have geriatric care? That's the question. And what did we learn in Israel?
Как это работает? Да.
As you all know, geriatrics is a multidisciplinary specialization. As Claudia also mentioned, it needs a doctor, it needs nurses, it needs a physiotherapist, an occupational therapist, a speech therapist, and it's different to something like internal medicine, because internal medicine relates to diseases. For example, if a person comes to the hospital with a fever and is coughing, so internal medicine will relate to whether he has pneumonia or he has bronchitis. But geriatric medicine relates to also whether he has fever and whether he has pneumonia, but who's his family, how does he function. We are a specialty that is function-oriented. So in Israel, when geriatrics started, it was mainly as another ward, another unit in hospitals looking after older people, like internal medicine. But if someone was 65 or more, usually 85 or more, he would go to geriatrics. And if he was younger, he would go to internal medicine. But their treatment was similar. But that is not enough. What happened in Israel is that geriatric services and geriatric hospitals developed in order to do diagnosis, assessment of people who have geriatric syndromes, such as falling, cognitive changes, functional changes, mood, depression, anxiety. And so what developed were multidisciplinary clinics and homes, hospitals, in order to look after all these aspects of geriatric care. And as those of you that have visited Israel know, we have today in Israel, we have geriatric wards in acute care hospitals. We have geriatric consultant units where I, for example, at the Rambam Hospital, don't have inpatients that I look after. I go throughout the whole hospital, from internal medicine, orthopedics, neurosurgery, the emergency room, and I see older people in the hospital as part of a multidisciplinary team with a nurse, social worker, etc. But like here in this beautiful center, we also have, not as beautiful, sorry to say, we also have rehabilitation hospitals for geriatric patients. We have chronic care hospitals for people who need to be chronically looked after in the hospital environment. We have wards for people with dementia who need to be looked after, that they cannot disappear, get lost. For those that have been to Israel, you know that some of these geriatric hospitals have nearly 1,000 beds. There's Shmuel Arofeh, and there's very big geriatric hospitals today which give all of these services, from rehabilitation, chronic care, and one other aspect which I'll mention. And it's all covered by government funding. There's one area which is developed in Israel which I think is probably unique throughout the world, and that is that we have units for people who are chronically ventilated, on chronic ventilation. And most of those units are in geriatric hospitals. And we have hundreds of people on chronic ventilation in Israel. So in other words, an old man who's 85 and he develops lung problems and he's resuscitated or ventilated and they cannot get him off the machine, gets a tracheostomy tube and goes to a chronic ventilation unit where he may live for 3 or 4 years in that condition. And there are big arguments in Israel today about this issue. The first question is, are these patients supposed to be in a geriatric hospital? And second of all, what are the ethics of keeping someone who may be severely demented, have severe dementia, on a chronic ventilation machine for many years? And what is the funding? You're an expert in health economics. It costs a lot of money as well. One of our geriatric hospitals, Herzog Hospital in Jerusalem, have, if I'm not mistaken, Zahaba can correct me, over 100 children that are chronic ventilated in a geriatric hospital. So what's the role of a geriatrician? That's your question. Well, a geriatrician looks after everyone that no one else wants to look after. That's what I say. But I'd like to add one other thing, that in Israel, 97%, and I think it's probably more in Russia, 97% of people older the age of 65 live in the community. So over the last few years, Israel is developing many services, geriatric services, for the community geriatric patients, including home care, hospital at home care, hospice care, in order to provide care for old people in their own homes.
Еще один вопрос в связи с тем, что вы отвечаете. А насколько эффективнее нахождение пациента, когда он находится дома, да, и мы не говорим о тяжелых случаях, мы говорим только о ранних каких-то стадиях проявлениях, или в клинике, где лучше, да, то есть насколько можно помочь ему, если он, например, сохраняет обычную жизнь в своей привычной среде?
The answer is yes, yes, and yes. I believe that every person should be able to stay in his own home and his own environment as long as possible. If they have a problem, a cognitive problem, then we have to come in as geriatricians and help them and their families to cope with the cognitive problem at home and to stay in their own environment. And this is even more important for people with dementia rather than MCI.
Да, я как раз хотела спросить про деменцию, поскольку у нас тема беседы — это диалоги о деменции, и о работе с людьми, которые живут, да, с родственниками, с родными. Что, меня лично это интересует, мы много писали на эту тему. Должен ли врач, вы ответили, да, что он должен подготовить всех, кто рядом, объяснить. А что нужно объяснить, что нужно сказать? То есть какие основные, может быть, вы выделите 2, 3, 4 каких-то пункта, темы, которые нужно обязательно донести врачу до родственников пациента?
So I think that the answer is at 2 levels. One is the level of professional care, and one is at the level of nursing care. And I'll explain myself because I'm not saying that nursing care is not professional. So professional care means the geriatric team. In other words, do we have the right diagnosis? Is the patient on the right medication? Have we provided the correct professional advice to the family? For example, in Israel, it's common to have that if someone falls at home, they have a radio in their home that they can push a button on a watch and get through to a central unit that know that they've fallen, can send an ambulance and come and help them. The physiotherapist professional help has to be, does the patient have good access to the shower, to the bath, to the facilities in the home? And the occupational therapist will come and check whether the house is safe. Is it good to have gas or electricity in the house? Is the door, are you able to open the door from the outside in case someone cannot get in? This is all part of the professional service that has to be given. But then the patient also needs nursing care. What do I mean by that? You need someone to bathe him, to dress him maybe, to make meals for him, to take him outside to walk, and that's given in Israel by non-professional nursing aides, mainly foreign workers from the Philippines, from Ukraine, from many countries. Israel has many, many thousands of foreign workers that come and look after old people at home for a few hours a day, 24 hours a day, and this is paid for by the government, by the Bituach Leumi of the government, which is controlled by the government. Every citizen pays insurance every month from his salary, and if he needs help when he's older or when he needs support as an invalid, he has an accident or something, then he gets paid by this fund. It's like a government insurance fund. And for this reason, this is probably the most important reason that many old people in Israel are being looked after at home and not in long-term care hospitals. And it costs billions of shekels, and they're already talking about another 10, 15 years that this insurance fund is going to go bankrupt. So you have to get old quickly in Israel.
В работе с пациентами с деменцией мне необходим комплексный подход. Это психологическая составляющая, это медикаментозная составляющая и социальная составляющая. Если в процентном соотношении, на ваш взгляд, как поделить важность этого для пациента? Вот какая из этих частей, из трех, она важнее?
As you know, every old person is a world by himself, and it all depends on the situation of that patient. I'll give you an example. He was 82 years old, his wife was 81 years old, they had no children, and they lived in Beersheba together on the second floor of and he developed Alzheimer's dementia. Clinical problem was, number one, he would walk out of the apartment any time of the day or night and get lost. And the second thing is he'd get very agitated and aggressive at times. We saw him in the clinic, medically, gave him his medications, and then one day when he came to the clinic visit with his wife, the wife looked terrible. The wife looked very ill. So I said to Claudia and the social worker, speak to the wife, see what's bothering her. This is multidisciplinary. So while I was examining the patient, they spoke to the wife, and it turned out that the wife, in order to look after her husband with Alzheimer's dementia, and to prevent him from leaving the apartment and getting lost, she hung up in front of the front door inside bells, so that when he came to the front door, she would hear the bells ringing and know that he was going to leave the apartment. And she would jump up and run to the door and try and stop him. And if she couldn't stop him, she would run out with him in order to keep an eye on him and see that nothing happened. And the other thing is he was aggressive. So she would sleep, she said she would sleep in the night with her palochka, a walking stick, under her cushion, so that if he would get too aggressive, she could have a stick in order to try and stop him being too aggressive towards her. And she said, the reason I'm not looking good is I have not slept in the night for weeks, because I'm always listening for the bells and I'm always ready with my stick. So it's clear that the treatment of a patient like this is to find a social solution before his wife will get ill and die, and he'll carry on with his Alzheimer's disease. And what we did is we got a Filipino worker to come and to live in the apartment, and he would look after the old patient, and the wife started going out with her friends and having a good social life and started living again. So that's the type of treatment that a geriatric team has to give for a patient with dementia. Does that answer your question?
Я как редактор Psychologist, да, и хочу спросить, насколько важна психологическая поддержка, не поддержка, а работа с дементными пациентами в лечении и в устранении каких-то проблем и неприятностей. То есть у меня вопрос именно про это.
So, in the realm of dementia, the psychologist has two roles. In Israel, mainly at academic memory clinics and academic institutions. In North America, probably many of these centers, the psychologist is the neuropsychologist. He's the diagnostician. He's the one that does the cognitive testing to see if the person has a problem with memory, orientation, language, etc. So a psychologist is number one, the diagnostician, in order to assess what's the cognitive problem. But the second aspect of the psychologist is to give support to the patient, because many, many patients with dementia have some understanding of what's going on, and they become anxious, depressed, and very concerned about the fact that they're losing their cognitive ability. Unfortunately, in Israel, in that field, very few psychologists are actually giving treatment. And we tend to give mainly drugs, antidepressant drugs, anti-anxiety drugs, and less to give an emphasis on psychology. And one of the arguments that supports not developing psychological services is that many patients with dementia do not have insight. They do not understand what's going on with them. And for a person to have good psychological treatment, he has to understand and have insight. And so that's one of the reasons maybe that it's not developing. There's a joke that they say if someone comes into a memory clinic and they look at the doctor or the nurse in the face and they say, "Doctor, I have Alzheimer's disease. I came for an assessment because I'm sure I have Alzheimer's disease." So all of us who work in the field say, if someone says, "Doctor, I have Alzheimer's disease," he does not have Alzheimer's disease. But if someone comes in and sits down with his wife and you say, "How are you?" He says, "Doctor, I'm fine, nothing's wrong with me." And you look at his wife and she goes,
Если вы посмотрите на его жену, и она уже сходит с ума,
she says he can't remember anything, he can't do anything, then he's got Alzheimer's. And there's a name for that in the professional world, that's called anosognosia, that people do not see their own problems. That's one of the signs of Alzheimer's disease.
Ну и в связи с этим сразу вопрос не про Альцгеймера, про деменцию, а про методики раннего диагностирования на ранних стадиях. То есть как это устроено, как это работает, как применять раннюю диагностику.
What's the difference between Alzheimer's and dementia? Dementia is a syndrome, which means that it's a syndrome of many symptoms, memory, other cognitive functions, physical function. So dementia is a syndrome. Alzheimer's disease is the most important disease causing the syndrome of dementia. So therefore we say that someone has the dementia syndrome caused by Alzheimer's disease. But it can be the dementia syndrome caused by other causes, vascular, Lewy body, Pick's disease, etc. etc. So the process for assessing dementia and deciding what disease the patient has is some ways very simple, because it's a clinical diagnosis today. It's clinical, not based on laboratory or examinations or MRI or CAT scan. It's today still a clinical diagnosis, which means that it needs a doctor, a nurse, a social worker to make the diagnosis, an occupational therapist. But it's very important that that doctor, nurse, social worker, the clinical team are very experienced and knowledgeable in the field of dementia. And when we diagnose based on the history that the patient gives us or the family, and on neuropsychological testing or cognitive testing, and on what we call exclusion investigations, to exclude other causes of cognitive. And for that reason we do blood tests, laboratory tests, and we do CT, and we do other investigations in order to see that there's no other cause for what's happening with the patient. And we work on very clear protocols today, and there's no reason that any multidisciplinary team here, that senior group or anywhere else, cannot learn the procedure and do an evaluation for dementia. I think you should set up, Alexei, a memory clinic right here in this building.
Есть ли вопросы в зале?
У меня вопрос в связи с разговором. В протокол психологической поддержки входит ли использование музыки? Потому что мы знаем, что есть музыкальная терапия, она очень эффективна именно при работе с памятью. А какой опыт есть в практике?
Okay, so in order to put everything into context, if we talk about dementia caused by Alzheimer's disease, there is no treatment in the year 2019. There are interesting, I'm talking about medications. There are interesting new directions, which I'm not going to talk about at the moment. If you want, I can talk about it. But because there's no medication which can cure Alzheimer's disease, we have to give symptomatic treatment. And there are drugs that give symptomatic support, Exelon, Acenta. There are drugs which may slow down the process. So therefore, the best treatment of Alzheimer's disease, which is also symptomatic, is the non-pharmacological treatment. And non-pharmacological treatment includes many aspects, including physical exercise, cognitive training, and you have right here a unit for cognitive training that we saw on the computer, and many other aspects such as music therapy, dancing therapy, which we know is very good for Parkinson's disease. And one of the important innovations which come from Holland, the Netherlands, is the Snoezelen room, where people go in and there's background music and there's lights and there's all types of stimulants which can calm people down and improve their cognition. So there's many important aspects of non-pharmacological treatment, and whatever works is good. So obviously the worst thing to do is to sit a person with Alzheimer's disease opposite the television, because that's no good. Doesn't stimulate the brain.
Уважаемый профессор, меня очень впечатлил вот этот случай, когда жена был агрессивный муж, и жена очень страдала. И вот вы сказали, что приглашаете в этом случае социального работника или какого-то специалиста, который как бы охраняет жену и соблюдает покой в этом доме. Но этот специалист тоже один, и он тоже когда-то спит. Вот как в этом случае? И у нас часто, вот у меня просто есть такие семьи, и просто обращаются к психиатру и назначают психотропные вещества. Вот, может быть, мы потом об этом будем говорить. Вот как у вас в этой ситуации?
So obviously the Filipino worker is a human being and should be treated as such. So in the case that I mentioned, so the Filipino worker would sleep during the day hours and be up in the night with the patient, and the wife would look after him during the day hours. But in some patients, they have two Filipino workers, one for the day and one for the night. The family have to add funding. It's not all paid by the government. But if you don't have any other option, then the one option we all go through in Israel as much as in Russia is we give psychotropic drugs. But psychotropic drugs are bad for people with dementia. They are much quieter. That's good, right? Right?
Они
They're
тише, они становятся тише. Это хорошо? Вопрос к залу. Когда мы грузим больного психотропом,
But they are more confused.
Но они более
And they fall, and they make their hips, and they knock their heads. So we try not to give psychotropic drugs unless we have to.
У меня такой вопрос. Вот эти пациенты, которые страдают различными видами деменции, Альцгеймера, они у вас по жизни наблюдаются и ведутся к кураторам каким-то определенным, либо это действительно монофункциональная какая-то группа, которая за ним наблюдает. И препараты, которые получают дементные больные, такие же, как вот так, катинол, мемантин, они у вас на государственной поддержке, либо покупаются семьями пациентов? Спасибо.
Okay, so just quickly to put aside the drugs for Alzheimer's, in Israel there are two drugs that are approved by the government, paid by the government for Alzheimer's. One is donepezil or Acenta, Aricept. The other one is rivastigmine or Exelon. So those are the two drugs that are paid for by the government. All the other drugs, memantine, etc., the patient pays privately. Regarding the physician who looks after the patient, that's a very important point. In Israel, every citizen has medical care provided by one of 4 sick funds, or Kupot Cholim is one of 4 funding agencies which have to provide all medical care to every person who's a citizen of Israel. Which means that every person in Israel has a family doctor, and the treatment is provided by the family doctor and the family doctor's clinic. The geriatrician is a consultant and advisor, but he does not treat the patient on a day-to-day.
Вот если учитывать, что в России вот не существует семейного доктора, кто должен, вот кто эта ступень первого обращения человека, откуда к гериатру вот в такой системе должен прийти больной?
In Israel, we, in many respects, went in the opposite direction that you are going. And what has happened in Israel for many years, historically, all psychiatric care was given by psychiatric hospitals. Over the last 15, 20 years, there's been 2 big moves in Israel. One is for a reform of psychiatric care, and the second is for a reform of geriatric care. The psychiatrists got their reform. So a few years ago, all the outpatient psychiatric care went to the community outside the psychiatric hospitals, and you now have psychiatrists giving psychiatric care in community clinics. Well, is that a good thing?
Разве это хорошо?
I'll tell you no.
Однозначно нет.
Because what's happening is before a psychiatric patient would be able to come and see within a very few days some physician psychiatrist in the hospital, and now they have to wait sometimes for months in order to see a psychiatrist because there's not enough psychiatrists working in the community. The second issue, what Zahava mentions, so as I said, in psychiatry, it's gone from the hospitals, you still have hospitals, but community psychiatry is now developing. It'll take time until it's sufficient. But the second issue in Israel, which is very problematic, and that's what Zahava mentioned, is that when someone has organic brain disease, not psychiatric disease, in other words, he has dementia, then he's no longer under psychiatric care, he's under geriatric care. So I see every week many patients who come to the emergency room because they are restless, aggressive, confused, or whatever, and they've had schizophrenia for 30 years, or 40 years, or 50 years, and now the psychiatrist says, well, he doesn't have schizophrenia anymore, he's now got Alzheimer's disease. It's now your problem as the geriatrician, not my problem. This, my dear friends, is the protocol. It's very complex. You'll all get the presentation. It's all, there's another 30 slides, which explains everything. But all you have to do, and this is what we did in the memory clinic, is you have to take a history, examine the patient, do a neurological assessment, do cognitive testing, laboratory work I told you, check whether he has depression, and if he's got depression, treat it. Check if he's got cognitive decline, do neuropsychological testing. Check if he's got functional decline, if his function's not good. And if he's got both cognitive and functional decline, he has dementia. That's all there is to dementia. It's very simple. To do this assessment, we used to do it in Beersheba, took about 2 hours.